Welcome to Unlocking Transformation, Navigating the Interoperability Landscape in Human Services with NYeC and Foothold Technology. I'm Elliot Masuda, the Community Engagement Events Lead at Foothold Technology, and I'm excited to hear this conversation today and presentation. So without further ado, I'm going to hand it off to my colleague, Alex Atkinson, to kick things off.
Thanks so much, Elliot. My name's Alex Atkinson. I'm our product manager for data and interoperability here at Foothold Technology. I'm going to lead off with some remarks with my colleague Paul Jones, who's our Senior Director of Strategy and Operations. And then Rachel Eager and Nicole Casey from NYeC eHealth Collaborative are going to dive into some really exciting material. And then hopefully we can have a robust discussion afterwards. We are really lucky to have Rachel and Nicole from the NYeC eHealth Collaborative with us today. The NYeC eHealth Collaborative, also known as NYeC, runs the state interoperability backbone in New York State, which is called the SHINY, also the State Health-Wide Information Network for New York. And they play a really important role by keeping the state connected. That includes healthcare providers, vendors, consumers, the health information exchanges, also known as RIOs or Regional Health Information Organizations. And we wanted to hold this event because we're at a really pivotal point in like the interoperability, like what I would call like the growth cycle. We've had probably about a decade plus of time working in the current interoperability landscape, as I frame it. And I think in the next 10 years, we're going to probably see growth in use cases and usage increase dramatically. And that's why we really wanted to engage the Footholds community, both on the awards and the FCM side, because you guys are going to play a really, really important role. So I just wanted to share some background on the relationship between Foothold, our customers, and the SHINY. We currently have 66 awards customers that are connected to the QEs, which are also known as the RIOs. That includes the Bronx RIO, HealthX, Healthy Connections, Rochester RIO, and Hicksney. There's one other RIO called Healthy Link that we were in the process of connecting to, but the customer opted to change networks, but that's no fault of them. And we have all of our FCM customers also connected to HealthX. This participation with the SHINY is given our customers three major benefits, but there's other intrinsic benefits as well. The biggest one I would highlight is clinical event notifications. That has made the single biggest difference in care that I can discern for all of our customers. I know we have customers that if they get an alert that someone's shown at the emergency department, they send a peer to go help. Others will help coordinate discharge care or coordinate social services after discharge. It's just been massively important. The other major benefit is that our customers can help create a single source of truth. Actually, I should say they can access a single source of truth via the RIO portal. If you are working with a RIO right now and you're not doing this, it's something we'd love to help you do, because you can see a patient's whole journey in one place, and that could be really powerful as you at an awards agency or an FCM health home look to help coordinate their care. And then the other major use case is that you have a lot of control as a contributor of data to make sure that if a consumer, member, individual, patient has an encounter with the healthcare system, that their information's up to date. That is really important. If a nurse or a physician or physician assistant is working in a chaotic acute care setting like an emergency department, the fact that you've made sure that their medications are up to date can make all the difference in the world in making sure that there's a successful outcome post-discharge. So it is really awesome. There's a lot of other use cases too, such as making sure that there's data for system delivery improvement, making sure that consumers have control of their own healthcare records. And I'm sure the NYeC eHealth Collaborative folks will talk about some of that. this is what interoperability looks like right now. We're using direct messaging for communicating alerts to our customers. Some customers are also using direct messaging to send referrals as well. But then we have connections with the health exchanges and awards apps. I show this slide because we're moving to a new landscape shortly. There's been one piece of legislation. One is a waiver to the Medicaid submission in New York that are going to make a major impact on interoperability in the US and in New York State. And I think this is a lot of why we want to talk to our customers and make sure that you guys are engaged in this conversation and can ask questions too. Because I think there's three main things that are changing. Like there's a technical change, which we're handling with FHIR. FHIR stands for Fast Healthcare Interoperability Resource. You're going to hear about that a little bit more today. It's an API-based exchange standard that is going to let us essentially send more data more nimbly and make sure it's targeted. An API just means that instead of sending messages like it's email, we're going to have the capability to, in a more modern way, let other applications pull data out of awards. There is going to be like policy changes. It's going to make sure that organizations can, essentially if you have when we talk about the social care networks, if they want referrals and they want it coded a certain way, we're going to be able to adapt to that. And then there's also going to be user interface changes. So like when it comes to there's going to be a new functionality called Smart Apps, which you can literally launch an app out of awards and have it use a standard interface. To the user, they're probably not going to care if it launches just like the e-prescribing application or something else. But to a vendor like us, it's just going to make it a lot easier to integrate and validate different apps with different use cases. So if there's like a referral app like Find Help or Unite Us, we're not endorsing anything at the moment, but we'll have the ability to add that in much faster time to market. So this is all really exciting. The other exciting part about what the Cures Act and the waiver bringing is the fact that it's really uniting a lot of different groups that were working like in silos. So like medical coding, networks being able to talk to each other, and all using the same technology is all harmonizing. And it's really great that everyone is getting on board with this because as a vendor, it makes our life easier, but it's not about making our lives easier. It's about us being able to deliver features. But we'll have a much faster time to market to deliver these features because everyone's now using the same standards. And then this is what it's going to look like as we move forward. We're really hoping that we can leverage FHIR for a lot of the interoperability activities that we have today. May not look exactly like this, but we're hoping it'll get there and we'll be able to deliver all the features that you need to be successful in the future. And then just some quick remarks about the Shiny. I think I've covered some of these already, but the NYeC eHealth Collaborative folks are really wonderful because they wear so many hats and they coordinate between so many different entities and hear our voices as stakeholders. And they also provide the critical link of making sure that data is interoperating between the RIOs. So like if you are connected to HealthX, but you have members that are receiving hospitals at a hospital that connects to HIXNY, the Shiny is making sure that those alerts show up at the place they need to and get provided to the users and providers they need to. So it is just really important. And then, yeah, to my other point, the Shiny provides just an awesome link between all these disparate partners, make sure we're all working in the same direction, using the same data standards, and helping everybody get to where we need to go with interoperability. So I welcome Nicole and Rachel. I welcome all of you guys here. Please ask questions. And this is just a wonderful opportunity for you guys to engage with us, and we're looking forward to it. Having said all that, I'm going to pass it to Paul Jones.
Hi, everyone. I only want to hop on for about 30 seconds. Really excited to be here and really excited for this conversation today. I know we have folks on the call that are awards customers and those that use our FCM product. So not everyone here may be aware that Foothold currently works with health homes across New York State. And with the passing of the 1115 waiver, um, we've been we have a team diving deep into the requirements and looking at the social care networks. Alex, you can go to the next slide. We've been looking at the requirements of the social care networks. And all I want to say is we're working with organizations through the requirements for the social care network application process. And this isn't the forum to go into any details, but for anyone on the call that is curious about the waiver, social care networks, and how Foothold may be able to support you, there will be information in the follow-up email. Thank you.
Awesome. And Nicole and Rachel, I'm going to share your presentation now. One sec, and then you can take it from there.
Rachel, do you want me to kick us off?
Sure.
Okay. Can you go to the next slide? So hello, and thank you for joining us today. My name is Nicole Casey. I'm the Director of Shiny Partnerships and Initiatives at NYeC. Today, I'm going to be presenting an overview of the Shiny, the statewide health information network for New York. I'll begin highlighting the roles and responsibilities of the Shiny, how it's comprised, and then just provide a high-level overview of the Shiny roadmap and our strategic principles and vision and some important initiatives that are happening across our enterprise. And then my colleague Rachel, our data quality manager, will discuss how the Shiny, how NYeC, the Shiny, and the QEs have been preparing for the 1115 waiver. Just really quickly before Rachel introduces herself, speaking of the waiver, just before we start and just to reiterate what Paul just mentioned, we do work closely with the state on innovation of the Shiny and advise them on key initiatives that go along with interoperability and such. There is currently an RFA open, as you all probably know, for SENs and how the waiver will be implemented. So if there's any questions that pertain directly to, the waiver or anyway, the RFA application process, those should be directed directly to DOH in the states, as we have no oversight and knowledge outside of our limited role, which Rachel will go into a little bit later on in her presentation. But Rachel?
Just to quickly introduce myself. Hi, everyone. Happy to be here. I'm Rachel. As Nicole mentioned, I'm the data quality manager here at NYeC eHealth Collaborative. Much of my role is looking into data and specifically around standards and validation. So I'm hoping to get a little bit into that with you, not too in the weeds, but enough where you at least have some resources around what we've been working on and have been covering through a lot of work with the Gravity Project. So looking forward to explaining that a little bit more later.
All right. Next slide, please. We could probably skip over the agenda slide. I think you covered that. This slide really just helps give you a sense of key roles. The New York State Department of Health is the funder of the Shiny enterprise. As such, we have a DOH-funded public HIE here in New York State. And as the New York eHealth Collaborative is the state designated entity, we take on much of the policy, governance, and programmatic work. But the direct work with vendors and providers, like Alex mentioned earlier, is at the community level, which is addressed and taken care of by the QEs or the qualified entities, as you may know them also as RIOs. They partner with NYeC and the Department of Health to provide thought leadership and deliver the Shiny services as they support care coordination and they meet performance goals and metrics and innovative healthcare initiatives through our work with them. Next slide, please. So the Shiny is a network of networks located in New York. The Shiny facilitates the secure health information exchange of patient health information and connects healthcare professionals statewide. In our partnership with New York State Department of Health, NYeC developed and manages the technology platform that connects the QEs and enables the sharing of data statewide. We ensure, through that process that the Shiny provides access to a patient's electronic health medical record and health record wherever and whenever they need it. New York's HIE is a federated model, meaning it's a network of networks where the QEs connect up to the one statewide infrastructure. The QEs are responsible for providing the services that allow providers to securely access patient health information with consent. In New York State, we have 6 QEs that serve as the backbone of the Shiny. And by utilizing the Shiny, healthcare professionals make informed decisions faster, enabling collaboration, coordination to improve patient outcomes, reduce unnecessary costs and tests and procedures. Next slide, please. So how does a QE connect providers today? So all 6 QEs connect organizations from across the care continuum, including hospitals, clinics, FQHCs, home care agencies, payers, ambulatory practices, even EMS agencies and community-based organizations and others. All providers that are looking to help improve the care for their patients by contributing data and by viewing data with consent from the patient. Ultimately, the goal is to develop better patient care and care coordination at each point of care so that the patient may go through and have each provider has access to all of their records. The Shiny is associated with approximately $160 to $195 million in annual reduction in unnecessary healthcare spending, including significant savings to both Medicare and Medicaid. The study is on our website, which is linked at the bottom of the slide, or yes, it's linked on the bottom of the slide that you can be found later on. We will be sharing these slides. And then next slide, thanks. So as I mentioned, the QEs are positioned across the state and cover each geographic region. Each QE went through a state certification process back in 2015 to become qualified entities, and they still go through a regular renewal of certification process on an ongoing basis. All QEs provide a standard set of free basic services to their participants, which are listed here. And all these services may look and feel different for each, depending on which QE you're connected to. All core services provide the same functionality, and most of the core services are provided at no charge to participants, besides any one-time setup costs. There's an asterisk between across a couple of these, which essentially means that the service is front-facing, where some of the others are behind-the-scene functionality. Next slide. So I just wanted to mention consent. While consent is not required for providers to send data to QE in New York, New York is an opt-in state, meaning that the patients need to provide written affirmative consent for treating providers to view their data. Currently in New York, there are 2 levels of consent, which require 2 separate consent forms. And then in a couple of slides, I will talk a little bit more about how we plan on evolving consent in New York and the future of what that may look like in a little bit. You can go to, yep, perfect. So here's a visual for our Shiny roadmap. Some of the items to address our strategy and implement our strategy are near term, where others may take some time, but overall, this is the direction we're going based on stakeholder feedback and direction from the Department of Health. So back in January 2023, NYeC received a letter from the Department of Health instructing the Shiny to prioritize certain services and specific strategies for the network in an accelerated fashion. We must improve support to public health agencies and become more efficient and building on the strengths of what we already have and the local relationships of the existing model that the QEs have within their regions and communities. So as I mentioned earlier, the Shiny connects New York's 6 regional health information organizations, and the QE store and share patient health information with participating healthcare professionals with consent to quickly access electronic health information and secure exchange data statewide. The current architecture, it played an important role in getting to the point where we are today, but it really lacks uniformity and nimbleness with the data sometimes being siloed across regions. So the state is really looking for the Shiny to provide consistent and seamless statewide services. The existing Shiny infrastructure, like I mentioned, really helped us achieve that broad connectivity and has really built in the engagement in local communities. But the model is cumbersome when it comes to a statewide service or supporting important initiatives like the 1115 waiver. So, what we're planning on doing is building statewide services using modern technology, and over time grow and expand the services that are offered. So how are we going to do that? The most pressing obligation for the Shiny is to support the Department of Health's public health and Medicaid units with statewide data. So to be able to do that and meet the needs of the public health agencies, the Shiny will first aggregate data from the six QE repositories into one single statewide repository. So as the data is combined and the rules for the data and the use of the management and privacy and protections become shared responsibilities. So the implementation of a centralized data repository, or you may have heard from your QE we're calling it a data lake, will really benefit New York with significant cost savings over time compared to the current model, there's 6 different QEs, 6 different technologies and infrastructures that are paid for multiple times. So we're hoping with this approach of, shared infrastructure and technology, that the prevalence of duplicate records will drop significantly and statewide innovation can happen, that much faster. So on the note of, redundancy and duplicate records, the Shiny needs to be more efficient and reduce redundancy. So we're looking to really address the way HIE services are procured and provided across the state. So, we want to make sure we're making data available wherever and whenever we need it, with transparent and, statewide data use rules. We really want to continue to, preserve the regional relationships of the QEs and the support of the local collaboration that happens at the regional level. So we're now looking to change the way things are in terms of that. A lot of the change, in terms of technology is really behind the scenes, and it really should be seamless for providers. In doing that, we're really hoping that, we're going to be able to provide timely and high quality data services to the Department of Health. We really want to, thinking about TEFCA, we haven't, talked and touched on TEFCA, but we really want to leverage the national networks as they, work through their implementation and how that's going to work. We want to be complementary to them and really make sure that we're an asset. And in doing that, it'll really allow state funds to really focus on innovation and improvement in New York. And then really just reducing the cost of burden to a QE as well. It costs a lot of money to the state. The state has invested a lot of money to date to get the Shiny up and running. So shared technology and shared costs will help reduce the burden in terms of costs anyway. And then, lastly, really just significantly improving the quality of data statewide and the availability of it. And then last thing on this slide here, we must meet local needs. We are working with the QEs to migrate to this, centralized technology. At the moment, we're working really closely with 4 out of the 6 QEs on migrating to shared infrastructure. So the Shiny is first and foremost a public health utility, and the Department of Health, as I mentioned, invested a lot of funding over the years in the Shiny to really be the sole health information network in New York, supporting the DOH's mission, public health activities, and health transformation programs. The Shiny has to continue to improve data exchange and support public health agencies to allow the DOH to really leverage the network to support the waiver, emergency pandemic response efforts, and other really vital public health initiatives that could be forthcoming. Yeah, that's a lot. That slide was a lot. So if you have any questions, please pop them in. But at a high level, that's sort of, that's where we're going as an organization, as an enterprise, and how we're planning to innovate to be able to support the waiver and other initiatives that might be forthcoming. And then I have one more slide before passing this over to Rachel. So in late 2023, an updated consent model was approved by both the New York State Department of Health and the NYeC Policy Committee, which is governed by the Chinese policy and procedures. The statewide model will be. And the policy committee is comprised of a variety of stakeholders across New York State, which includes QEs and NYeC and Department of Health and others. So this new policy will allow patients to consent once and allow most treating providers access to medical records. This new model will be implemented in 2024 or early 2025. We're still working out the details of how it's going to be rolled out and implemented, but once this was implemented up in Western New York a few years back and was very successful in closing the gap and sharing data in some circumstances. I think it's important to note here too that some of the providers in this audience service patients with Part 2 data. There will continue to be additional parameters in place that are governed by the current shiny policies and procedures and sensitive data sharing. But the consent model has to evolve as new initiatives such as the Waiver and social care service organizations currently have limited access, and they would need access on a limited basis to patient records for referral purposes. I'm certainly not an expert in our community, in our consent, but if there are any questions specific to consent, I can always take them back to the policy team if I'm not able to answer them here. And I think that's all I had.
All right. Hi, everyone. So today I'm just going to cover some high-level bullets around how NYeC has been really supporting and understanding social determinants of health data, or as we call it, health-related social needs data too. And you'll see those used sort of interchangeably throughout these slides. And I just want to point that out as a definition. The other definition I want to point out is the Gravity Project, which you will see reflected a lot. They are national standardizing bodies for health-related social needs data, and we've been working very closely with them to ensure that we're implementing some of those standards correctly. So on to the next slide, please. So what I really want you to grasp from this slide is that we've been doing a lot of work in parallel to figure out how interoperability of social determinants of health, specifically screening information, can be supported across the statewide health information network here in New York. One of our QEs that I just want to call out, Bronx Rio, has been leading a lot of this work since in 2022. They have put together a social determinants of health screening and functional and technical requirements specification that really drove a bunch of different projects off of this. This was a NYeC funded project, and we eventually then turned it into a Civitas/Gravity Pilot Award that the Bronx Rio applied for on behalf of the Shiny. So we've been working really closely with the Gravity Project. And then we took that award and kicked it into 2 tracks. Track 1 being the Shiny screening exchange support. So they've been working very closely with us to figure out standards and interoperability there. The second one, a DOH support project where Gravity just showed them what they have created off of that. And then currently, back in November, we started to build this sustainable technical infrastructure to support screenings and also other potential data that may come out of the, now approved 1115 waiver. So specifically around getting screening data to our Shiny data lake, which is our centralized repository in FHIR. And then on January 9th, as we all know it, the waiver amendment has been officially approved. So what I'm kind of showing you here is sort of this parallel track, and just looking forward, we're looking to make sure that we can also exchange other health-related social needs data in regards to the waiver. Next slide, please. So what I really want you to grasp from this slide is some lessons learned that we have found off of some of this work that we've done. The first one I really want to drive us to is that Gravity Project was a super helpful in technical assistance. They really worked us through the terminology that they have, the domains, the FHIR implementation guides, and sat with us, and we were able to really grasp, okay, what is the level of how do we support screenings and NYeC? Well, what are we doing here? Do we need a code here? And that's work that's going to continue going on because it's so important that we have sort of those national levers here to really understand how we relate that to the national landscape of social determinants of health data. The second one I'm pointing out as more of, okay, well, there is technology all over the place a little bit right now, and technologies at different levels. And we also know CBOs are at different levels and others who may have to support screenings. When we originally looked to pilot this, a lot of the QEs found that CSV data was getting this data in CSV was really the way that this could be exchanged. But there are others who are fire ready, as sort of Alex pointed out, and there are more that will be fire ready as we get through this. So another thing to point out is that Gravity Project very much aligns with FHIR. So we've been trying to work through those standards a lot. The next one I want to just talk about is adoption of social determinants of health data is very new, and we're all sort of working on this together. And so there's really a need to think through, okay, how are we implementing formats, data quality, transforming this data to different standards? All of those pieces are really important, and doing that consistently across not only New York State. So I think this is a really important lessons learned as we sort of dug into this about how do we do this consistently. And then the final thing I want to point out, and Alex sort of introduced fast health in healthcare interoperability resources earlier. But this again plays a really important role in business use cases for us because we needed to figure out what resources could support screenings. And eventually we decided to go with observation on the Shiny side of things because of the fact that we're able to document a need, we're able to document a domain. It's a more mature resource overall. And so these are kind of the conversations that, as an example, that have been coming up out of this work, and really important that we're understanding those technical aspects that play a role here also in how we are developing FHIR. Next slide, please. So on this slide, I just wanted to provide you with a few resources because I think these have been super helpful for me, and I think they could be really super helpful for the community too. So the first is the Accountable Health Communities Health-Related Social Need Screening Tool. This is what is in the RFA that New York State is looking to align to, and please reference that for more information. But I did want to just give that as a resource. And then the two others are the NYeC codes, so really specific to the Gravity work around how do you represent this data in NYeC. And finally, I just included a Gravity Project crosswalk because this is really interesting to see AHC, HRSN question crosswalk to a diagnosis of a patient with a health-related social needs. So just take these resources, and if you want to take a look at them, I think they've just been really helpful to me. So I wanted to share those out to the community. Next slide, please. So looking forward, the 1115 waiver support responsibilities. I wanted to share the slide. It's still in draft because there's a lot, that's sort of coming out as we're working through this, as you on the community end are also working through this. But just to give you sort of a sense of what the Shiny is looking to support, the aggregation of screenings, assessment results, referrals, and provision of service into our statewide registry or the Shiny data lake, as I referenced earlier, enhancing screenings potentially with better demographics information and chronic condition flags. And we're looking to get a lot of this data over to Medicaid Data Warehouse, making sure that we're supporting the SCNs where they're at and the HERO. And then delivering service screenings, assessments, results, and referrals data to the point of care And then finally, making sure that we're applying Shiny policies and procedures to data use. The other three listed here are possibilities right now that we're thinking about. Again, I just wanted to share this slide in draft because of the sense of we're really working through this with the Department of Health as we sort of move this forward. So that's all I had. I think we can move this on to Q&A.
So we don't have any questions right now, so let's give it a minute to see if anyone is, sends any questions. Again, I don't know if you saw in the chat, but if you have any questions, please use the Q&A feature in Zoom. And if you don't know how to use that feature, feel free to put your question in the chat, but our preference is to put it in the QA feature. And Nicole, Rachel, Alex, Paul, I don't know if you have any questions that you've talked to our providers or any of, that might facilitate some conversation as well. Feel free to do for that at this time.
Yeah, I was gonna say, I know sometimes it's scary to ask a question in a public forum. So if anyone, I don't know if you want to go back to the intro slide for Rachel and I, but if anyone has any questions, I think we put our email addresses in there. If not, I can type it in the chat. But if you have any questions and didn't want to ask in a public forum, please feel free to reach out to us directly. We're happy to talk offline. The QEs have, up until, the last couple of years have been the primary point of contact for most providers. Over the last couple of years, we really focused on stakeholder engagement, which is how we've, been connecting with Foothold and really just hearing some of the pain points, barriers. So we love talking to stakeholders and providers who are directly using the Shiny, who have some positive use case stories. We love to hear those too. But any barriers, if there's anything we could work into our long-term strategy in terms of implementation and ways that we can help and innovate, please feel free to reach out to either Rachel and I.
So we do have one question that just came in. Will the new statewide model include SAMHSA 42 CFR Part 2 data?
From what I understand, it will, but it's still going to be governed by the current Shiny policies and procedures. So there's going to be additional layer or step in terms of it's going to be available in terms of sorry, I saw the second question. It'll be governed by current Shiny policies and procedures. There's going to be additional parameters in place for Part 2 data in terms of sharing. The spirit of the statewide community consent model is a one and done. So patients won't have to opt in for multiple points of care. So if you see your primary care physician and you opt in to share your data, you're doing it just that one time. If you go to a specialist, the way the current model works, you also have to opt in there and then opt in, at all the different points of care. So this will hopefully reduce the burden for patients for forms and consenting at every point, at every level. But yes, it will be covered by 42 CFR and have additional parameters in place to ensure that sensitive data is protected at the same level that it is now.
And we will be, this has been asked a couple of times, we will be sharing the presentation and the recording in a follow-up email. So you also have everyone's contact information, all the resources and links that Rachel and Nicole both shared in their presentation. In the next week or so. So if waiting another questions, do any of you have any final thoughts? I know that it was where you hope the final thoughts on just like the waiver. I know that was a lot of anticipation for the waiver to be passed. On maybe any final thoughts that you want to give around the presentation as we wrap up.
Yeah, I mean, I'm interested. I mean, I agree. I think this is like a lot to process. So I hope everyone takes time to think about all of this. I'm interested to like understand if customers that are on the call might be like considering themselves in the CBO bucket. I'm curious if folks are collecting social determinant screenings now. Because if there's anything we can do to help you collect this data and transmit it effectively between now and the waiver, or even I would imagine this information will be like relevant outside of the SCN sphere as well. We'd be more than happy to talk about how we might be able to help you make better use of existing connections. But yeah, no, I know it's just a lot of information. It's a lot of changes. There's a lot of technical stuff going on. Our job is to make sure that you don't have to deal with that so much. And then you can just collect awesome data and continue to provide awesome care. So, but I think some of that is creating a feedback loop with groups like NYeC so that they can understand our space, and vice versa. So, I totally understand this might be overwhelming in this form, but, we'd like to make sure that, even if it's just some of you guys, we can continue this conversation.
Give it another minute. Otherwise, I think we'll call it a wrap. Thank you, Rachel and Nicole and Alex and Paul and for presenting and coming together to talk about this important topic. Oh, here we have one. Are there any plans to have hospital alerts received recorded directly into the hospital's module and awards, similar to how FCM currently operates?
Yeah, that's a good question. I know it's an insight that we've documented in our feature tracking application product board. But it is not in our roadmap at this time. It might be something that gets addressed as we make the technological move to FHIR. There's two issues, like technically speaking. The first is that we receive alerts by direct message right now. We made that choice way back when because every Rio at that time was sending alerts differently. If we had the opportunity to like get them in a consistent way when we set that functionality up, that's something we likely would have implemented. But it's something that we can definitely improve on because it is a really awesome feature that FCM has.
Awesome. So with that, we will wrap things up. Thank you again, everyone, for joining us today. And look for your inboxes with a follow-up with today's presentation and recording. Have a good rest of the day, everyone.